Good morning, everybody. My study is on risk factors for local tumor recurrence and metastasis in sebaceous gland carcinoma of the eyelid. So SGC is the most common eyelid malignancy in the East, and the incidence in India is twice that of what is seen in the West. And it is also misdiagnosed in up to half of the cases and are operated suboptimally before they present to a specialist. And aptly called the Great Masquerader, SGC comes in all shapes and sizes. At times they are hidden in plain sight like this, that you see only while everting the eyelid, but more often than not they present as chronic conjunctivitis, irregular pagetoid patch, or an unsuspecting nodule as of a chalazion. So the treatment patterns vary between clinicians, and the rates of recurrence and metastasis is varied, with those in the developing countries being more than twice as those of the West. And this could be due to higher incidence of SGC among our population, but it is crucial to know the risk factors that cause metastasis and recurrence. So there are many postulated factors, and the ones that are most consistently reported to be independent risk factors are pagetoid spread, canthal involvement, and a size more than 10 millimeters. So our study aimed to describe the clinical profile of SGC and the risk factors for local recurrence and metastasis in a single center with standard treatment protocol in a large series. So we did a retrospective analysis of about 183 patients histopathologically diagnosed with SGC operated at a tertiary eye care center. So the standard treatment for resectable tumor involved wide local excision with 4 millimeter clinically clear margin with MAP biopsy and intraoperative frozen section, followed by either direct reconstruction or a Tenzel's flap, or a Cutler-Beard full-thickness sliding flap, or Hughes tarsoconjunctival flap for lower eyelid defects. So the mean age was 57 years with a slight female preponderance, and the mean duration of symptoms was around 2 years. So over 60% had a prior history of surgical intervention with an average of 1 surgery per patient and a maximum of 10 surgical interventions before presenting to us. And excision biopsy was slightly more common than incision biopsies. SCC was found more in the upper eyelid in about 60% of cases. It was multicentric in about 3%, involved the phonics in about 7%, and caruncle in about 10%. And the most common AGCC stage was T2B. The largest diameter, either horizontally or vertically, was more than 20 millimeters in 36.6% of our patients. And the most common primary modality of treatment was excisional biopsy with clinically clear margin, along with intraoperative frozen section, and around 16% required excentuation. MAP biopsy was performed in about 62% of cases, mainly when there was a clinical suspicion of pagetoid spread or when there were atypical features, although clinical suspicion was present only in about 55% of patients. And among these, pagetoid above the tumor was seen in about 8.7%, and pagetoid away from the tumor was seen in 4.3% of cases. And the median time to recurrence in SCG reported is 22 months, and our follow-up was about 25 months. 8 had pre-existing metastatic disease, so out of 175 patients, local recurrence was seen in about 14% and metastasis in about 5% of patients, and the mean recurrence-free follow-up was 16 months and 21 months for recurrence and metastasis respectively. So in a more relatable terms, the incidence rate of recurrence was 0.12 per person per year, and incidence rate for metastasis was 0.04 per person per year. And among the Mets, 50% was to regional lymph nodes and 50% to distant locations. And so these rates were much lower than reported earlier from our part of the world, and the death rate was about 1.6%. On univariate analysis, the risk factors for local recurrence were prior surgical intervention and longer duration of symptoms, and those for metastasis were higher number of prior intervention and longer duration of symptoms and canthal involvement. Histopathologically, the factors affecting local recurrence were pagetoid away from the tumor and lymphovascular invasion. And when I say pagetoid away from the tumor, it's not MAP biopsy positivity. It is on the main tissue specimen when you find epithelial involvement away from the nodule and not right on top of the nodule. And those for metastasis, apart from clinical suspicion of pagetoid involvement, it was lymphovascular invasion. And please note that MAP positivity was not significant in this particular cohort that we found. By logistic regression, the independent risk factors were lymphovascular invasion and pagetoid spread away from tumor for recurrence, and size more than 20 millimeters for metastasis. Frozen section is important because we found just a higher number of recurrence in those who did not have frozen section, although it was not statistically significant. MAP biopsy, clinical suspicion was seen in 55% for pagetoid involvement, but was positive only in around 10%. So in conclusion, risk factors for recurrence and metastasis were identified. Frozen section is important, map biopsy is also important, but it might not have a high yield, so it's always important to look for pagetoid spread away from the tumor and deal those cases with caution. These are my references. Thank you.
It's a great study. Just a quick question. Map biopsy was done in all cases or in select cases?
Selected cases. When
But the outcomes of the map biopsy was not used as an analysis in the factors that affected metastasis.
We did. So we did not find, we didn't do it, so we did not do it in all the patients, we only did it in those with pagetoid, clinical suspicion of pagetoid or atypical features of the tumor. But when we used that as a variable, we did not find that a map positivity was significant for recurrence. I think why that was is because of an optimal management. When we found a map biopsy positive case, we did treat with cryotherapy and topical chemotherapy adequately for those patients. That's probably why we didn't. They did well.
So was there any patient who did not have a map biopsy done, but who came back with metastasis or recurrence?
I'm sure there was. I'll have to look at the exact number. Yes, there was.
Then that will be one of those cases in whom there was no clinical suspicion of pagetoid, but still came back with recurrence.
So in comparison to the other larger study, Dr. Shields' series, which looked at the risk factors, did you find any different factor, or your findings corroborate with the already published studies?
So the most important thing we found was this pagetoid away from the tumor, which is not really described. We always talk about size, map biopsy, but in the main tissue specimen, it's important to look at the epithelial involvement. It might imply that the epithelial involvement might be more focused around the main tumor, which might be missed when we do the standard map biopsy sites.
Sure, great, thank you. All right, that